Okay. Well, I'm Ingrid Estrada-Bellmann. I work for the University Hospital in Monterrey, Nuevo León, which is in the north part of Mexico. And the outline of my talk is to ask these questions. If the risk of developing COVID-19 is higher in PD patients and non-PD patients, clinical expression in persisting and new onset Parkinson disease, the outcome and the impact of the pandemic COVID-19 on psychological distress, physical activity, and symptom severity in PD. Very important, this point. Okay, we have learned at first from China and then from Europeans. And we have the first clinical manifestations associated with COVID-19 from Spain. And we this paper comes on April 12th of this year, and they have reported 92 cases that notified 131 neurological events that they divide in 16 categories. And well, as you can see, the movement disorders were 1.1% of these patients. At first, it's important, these clinical manifestations, because we always think that this virus was just for respiratory symptoms, and then we saw generalized manifestations. And China's paper says who are vulnerability to poor outcomes, and that were by age. The people who are 55 years and more, PD with more comorbidities, especially they see coronary artery disease, cerebrovascular disease, and heart failure, higher mortality with a clear preponderance of male sex, and increased risk for more severe forms of COVID-19 in advanced PD. But well, we have this paper published by Dr. Stanley Fan on 1992 that he looked for coronavirus in cerebrospinal fluid antibodies in patients with Parkinson disease. It's very interesting because we are like, oh, coronavirus, and coronavirus lived with us since many years ago, so it's not new. But it's interesting, this paper. On this other paper, the question that what happened with neurodegenerative and immunological disease, if they are more vulnerable to develop COVID-19. And they said that there is no significant difference in morbid mortality compared with the general population. And one of the things that I said before is that we think that the alpha-synuclein have a protective role against infection. And well, they think also that non-motor and motor symptoms have deterioration. Um, okay, Car, you're controlling my slides.
Oh, I'm sorry, I didn't mean to do that.
You changed the, okay. And well, the problem is that the infection with COVID may stimulate neurodegeneration by accelerating brain aging. And this is important because people who has been infected with COVID will have maybe post-COVID manifestations, and that's something that we have to be very waiting if it happened. But well, this is three groups: the Parkinson disease, the Alzheimer disease, the multiple sclerosis disease. They were all these diseases that were analyzed in this paper. Mm, Next, Carl, please, because I can control it. Okay. This is the paper that I talk about the repurposing of the drugs that we actually use for the treatment um, for Parkinson disease or for other epilepsy or other infections or other disease. And perhaps the most obvious candidate is amantadine, because amantadine was at first one recommended treatment of influenza, but now it has a high rate of resistance, and we think that it's not enough. But amantadine is one of the repurposing drugs for this purpose. Next, please.
Sure. So, yeah, I have you on control, but I guess it's not going well.
No, you're you okay. Yeah, thank
Yeah.
you. But what we have to know about the no, you changed the slide, Carl. Please,
I did? Oh, no, I'm
okay,
sorry.
yeah,
Oh,
yes,
jeez.
please. Okay. The interactions that we can have with the drugs that we use in the therapy of COVID. And we must know that tocilizumab increase levodopa levels and side effects. Carl, could you put the next slide, please? The
Sure.
next, please.
I'm trying. Oh, is that it?
No, no, no. Yes. No, yes. Yes. And the side effects that has been seen on chloroquine is ataxia, tremor, dystonia, and hypothetically inhibit autophagia and its purpose like anti-PD. Lopinavir and ritonavir has a side effect like the serotoninergic syndrome and Parkinson with the use of buspirone. And tocilizumab, we have to avoid toxic levels because it could happen myoclonus. The next, please. And then this slide, when I read the first time this paper, I have a very nightmare because the modus operandi of COVID-19 is that how we talk about the ACE receptors that we can find in the dopaminergic neurons and the neurons. And the virus enters the host cells and hijacks the cellular machineries for its own replications. It's like a terror movie because the COVID virus is the owner of our cells, and it affects all the pathways that maintain the cellular longevity RNA polymerase and leading the protein aggregation and its results to diseases like the proteinopathies. And it's just terrifying because what will happen with the cells that keep the information of these cells that has been destroyed to maintain the virus living in our brain. Next, please. Okay. There are several mechanisms that have been involved to the pathogenesis of viral-induced Parkinsonism. And well, it depends on the type of neural damage. It could be direct or indirect, because the virus has tropies for basal ganglia replication and subsequent neural lysis. And indirect because the virus activates microglia and release of pro-inflammatory factors and T cell response. There's loss of vascular integrity and hypercytokemia, and it provokes indirectly injury by hypoxic brain. And it's interesting because as we have on Parkinson disease the dual hit explanation of what happened, where begins first the pathology. If we think in olfactory nerve or if we think in vagal nerve. This is interesting because we have symptoms like nausea that could be the first manifestation of this direct neuronal damage. The next, please. Okay. This is the first description of patients from King's College and from Padua, from Professor Chaudhry and Antonini. And it includes 10 patients. It's very short. It's not enough statistically, but it's important because they describe the symptoms that they saw in this patient and the mortality that they have. And at the beginning of the paper, they comment that the receptors of ACE2 are highly expressed in dopamine neurons, and they are reduced in Parkinson disease because of the degenerative process. And therefore, severe acute respiratory syndrome related brain penetration may cause additional harm and worsen symptoms and may increase the requirement of dopamine replacement therapy. Later, we are going to see that, in fact, we have to increase the dose of levodopa by this reason. Next, please. They found that 40% of people with this age have mortality. It's 78.3 years, and lung evolution 12.7 years. 50% mortality with advanced therapies, and considerably worsen non-motors like anxiety, fatigue, orthostatic hypotension, and cognitive impairment. And it's very important because at that time, the patient presents psychosis. Next, please.
There we go.
Okay. This is the study of Lombardy. We have learned a lot from Italians, and they include 1,486 patients. And they found that the risk factors were obesity and respiratory symptoms. And they found also the protective effect of the people who take vitamin D, like the vitamin D intake. It's very interesting. Well,
Oh, I'm sorry.
no, that's okay. That's okay. But it's explained this table. Yeah.
Okay.
And there's a lot of studies of the role of vitamin D, and especially in elderly, um, because the elderly maybe doesn't have the same intake, or it doesn't have the same exposition to the sun, and we find low seric uh, 25 hydroxylase levels in serum. And in COVID-19, it has a function, pro-immune function, and anti-cytokine storm. And in Parkinson disease, like in others neurodegenerative disease, support innate and adaptive immunity, and it's like anti-inflammatory. I use a lot vitamin D before I prescribe it. I ask the patient to make protein, vitamin D levels, and it's important because I have um, a hypothesis that the people who has more inflammatory or more affected by Parkinson maybe are the people that has vitamin D levels lower. Next,
Okay,
please.
sure. So they have maybe a deficiency.
I think so. I take vitamin D also,
Uh-huh.
and I think it's well. There's a lot of papers and systematic reviews and about this, and it's very interesting because they saw in the Lombardy this this risk.
Yeah, I take it too. Not to interrupt, but I've been taking it all year this year since January 1st. I started
Mhm.
that day, and it really seems to make a difference for me and how I feel too.
No, and don't forget that we are not outside like before pandemia,
Yeah,
so we don't take sun as usual. So remember that vitamin D has to something with the sun and the skin, and that's one of the reasons that we don't have the same levels.
sure.
So
Okay,
it's good.
good
Okay.
point.
The clinical manifestation they found, the motor and no motor has shown decline, and specifically anxiety and the changes of dopaminergic therapy they have to make in these patients. The outcome, when we think the mortality in this series, they compare the mortality in the Italians, in the Italians that doesn't have Parkinson, in the mortality, in global mortality, and they found that in Italy they have a 9.5% mortality um, over the 50 years, and 12.5% over the 70 years. And in Parkinson disease, they find that 5.7% was the mortality rate. It's lower.
Interesting.
Okay, the next, please.
Next. Okay.
Yes. Okay. Um, this is the effects of COVID on Parkinson disease clinical features in a community-based case control study. And well, they report significance, especially in the clinical impression of severity index for PD. Next, please. Okay. The important thing, if we see this table, and you can see the patient with COVID and Parkinson disease, and the patient without COVID and Parkinson disease, and the significance of the therapy. was that during the COVID, the patient has needed to adjust the therapy during this period. So evident is that we need to look for adjust the drug if it's necessary during the infection of COVID.
All
Next,
right.
please. Okay. But other questions comes out that is what happens if the patient has a rapid worsening in Parkinson disease? And another thing that we need to have in mind is that maybe this worsening is because they may hide COVID infection. Okay, next, please. Okay. If we compare the series, the papers that has been published, we began with the Antonini and Chaudhry with 10 patients, and the mortality was about 40%. But statistically is not significant because it's the time of the size of the population that they study were a few. 10 is not statistically significant. And Fasano, I think it's the more maybe the best who reflects 5.7% of the patient have the risk of mortality. And if you look at the size and the design of the study, it's different, but it comes from 5.7 to 19.7 to 18.4%. And well, they describe the risk factors that they have also. And we have cancer, dementia, and bad adherence to the treatment.
Okay.
Next, please. Okay. But someone who doesn't have Parkinson disease, who can develop the disease, because if we remember 100 years ago, humanity was fighting against the Spanish flu, and there was a post-encephalitic or Parkinson post-encephalitic manifestation. And well, in July 8 of this year, Neurology published a paper from Spanish people who describe acute hypokinetic rigid syndrome following COVID infection. And they saw that scan, the nigrostriatal were reduced bilaterally, but they show greater deterioration of the asymmetry of the left. Next, please.
Interesting.
And then on October, maybe most of you, if you have Twitter, have been seeing this paper, a case of probable Parkinson disease after COVID infection. It was a man that traveled to the United States, got infected, and then go back to the Israel. He's living in Israel, and that scan show asymmetry, and the same as we saw in the Spanish patient. But in the Spanish patient, one interesting thing is that they tried to uh, give treatment with apomorphine and dopaminergic agent, and they did need to continue it because the patient got improved. Next, please. Okay, this is one of the my favorite slides and my favorite paper from Professor Bastian Bloem and people from Netherlands, and it explained what happened for everybody, not just for patients with Parkinson, uh, after the pandemic. We have an abrupt change of our routines in a very short time, and people with Parkinson disease have something that we call cognitive flexibility, and the cognitive flexibility has a lot of the dopamine has a lot of things to do with it. If we have not the good dopamine levels, we have poor flexibility cognitive. And and three things change. We have social distancing. We have the stress of a black swan. We don't know what will happen, the uncertainty, and we are not making the same exercise that we used to do.
Yeah.
And we are in like a spiral. If we don't go out from this, we are going to have bad evolution.
It won't
We
be
are in
good.
trouble. Yes, we
Yeah.
are going to be in troubles. And the way they told us how to fight this cognitive flexibility is by making exercise, mindfulness, and spiritual. Every of us has a different spirituality, and what we are doing now, that we are zooming and we are socializing by the technology.
Sure.
But the results of this, they saw that they have increased chronic stress, tremor, cognitive problems, problems with gait, and dyskinesias. Next, please, Carl. Okay. And last week, I think, this is the latest papers of Bastian Blum, and it talks about the impact of the COVID-19 pandemic on psychological distress, physical activity, and symptom severity in Parkinson's disease. Next, please. And it's very interesting because it's the same team that writes about these three things that abruptly change in our lives, and our lifestyles have been changed a lot. And well, this is the consequence for people with PD. The social distancing measures complicate regular care and result in lifestyle changes, which indirectly cause psychological stress and worsening of PD symptoms. Next, please. And
1 second. Sorry.
yeah, and the figure of the spiral, I love to share with my patients to explain, but sometimes I think they don't understand, the caregivers and the patients, that it's happening, and they are worried about my disease is evolution. No, 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 it's not evolution. They think it's all the worsening that we are seeing in this patient. Uh, it depends on the transitory of the stress we are living. But well, they compare um, a month before pandemia and living in pandemia, and they found that the symptom that worsened the most was rigidity, 42.6%,
Wow.
fatigue, 41.5%, tremor, 40.7%, And the less, well, was dyskinesia, constipation, speech problems. But, uh, there's a little percentage of improvement. And mostly, if you see the rigidity in at that time, the no has no change in 54.7%. um,
Amazing.
it's very interesting because we are living, most of us, we are seeing this, the patient symptoms worsen, and we have see these changes in these 13 problems. Next, please. Okay. On these 58 patients, on conclusion, they saw or they found four things. First, patient with higher COVID related stress or load experience higher PD symptoms severity, and its effect was mediated by the degree of psychological distress. It's very important this. And the second, because this stressful load, we can work on it, by making exercise, doing other things, mindfulness. You're going to see another paper that I loved about mindfulness and this stressor load. And the second, it's very important because the number of patients with PD that were physically less active since COVID-19 pandemic was 46.6% of the patient, and that worsened the PD symptoms. And third, show that symptoms that worsened most were rigidity, fatigue, tremor, pain, and concentration. And the fourth found that PD patients with high perceived stress levels experience more anxiety, rumination, neuroticism, and they scored lower on cognitive abilities, social support, trait resilience, optimism, and positive appraisal style. And this is important because I have a lot of patients that the caregivers and family are asking me if, do you think is going to be demented, or what is happening with this, the cognitive skills? It's getting worse. I think it's a stressor. The stressor load, it's very important. Next, please.
Sure.
Okay. We need to see the patient with all the interaction that we are living. The patient as as a susceptible host, the social and the environment that is around us, and the bad of the story that is COVID-19. Next, please. And since March, this slide is very blurred, but I think it's like now we have the vision of the COVID. It's like a blurred everything.
Yeah.
But we saw in March this paper about the hammer and the dance, and we are trying to keep low the cases of COVID, that the hammer doesn't go so up, and we don't have problems with that. And the dance, we're keeping dancing until there's an efficacious and safe vaccine and or treatment universal for people at highest risk first. And how we are keeping dancing. Next slide.
Sure.
We are keeping dancing, and we are having other hammers that we don't see. And this is the health footprint of pandemic. The first wave, we already live it, and it's the immediate and mortality and morbidity of COVID-19. But we all keep on at home. We have telemedicine with our doctors, or we are afraid to go to the hospital if we have an urgent condition, not a COVID condition like a stroke or like a cardiac infarct. And this is the second wave. The third wave is impact of interrupted care on chronic conditions, diabetics, hypertension, Parkinson disease. But the most interesting thing, and I'm very concerned about this, it's the burnout that we are all living, the economic injury that is less, the mental illness, and our mental health.
Mhm.
Next, please. It's very interesting, this. Okay. And this is the paper that published on these days, Bastin Blood, and the same team that the last papers I talk about. And it's about stress and mindfulness in Parkinson disease. We are just thinking about the future, but the clinical effect and the potential of the underlying that has this stress that causes think and think and think and think what will happen and where I'm going to be next year. I am be alive this Christmas. What will happen? We are thinking and thinking and thinking. My best friend is always counting who died, who is at the hospital. She's stressed about that, and we have to uh, keep working on thinking on the present. We are alive. Thanks, thankful. We are uh, good. We are fine, and that's all the meaning of the mindfulness. Don't
Yeah.
worry about the future, because if somebody told us that this will happen next year, we don't believe that will happen, and we think this is like I don't know, that's like a terror movie. It's a
Yeah.
crazy thing. We didn't believe that. Next, please. But we like the spiral, it's like a never ending story if we keep running through the chronic stress, because we so increase the levels of glucocorticoid, because it's our body who's is responding to this stress. We decrease something very important that we try to increase with the exercise, and it is decrease the expression of the brain derived neurotrophic factor, the BDNF. And well, we have to see atrophy of the hippocampal and prefrontal lobe, and the amygdala, and we are going to have susceptibility for depressive and anxiety disorders. But if we saw that we have this hippocampal and prefrontal atrophy, we have this inhibition axis of the hippocampal pituitary adrenal axis, and we begin again elevating glucocorticoid levels. And then we go to the pro-inflammatory mediators, and we are with high free radicals that are working on nigrous striatal cell, and it begins to have more loss of this type of cells, and the PD progression. And if we see the low cell, lower stress resilience, and we go again with the chronic stress. This is important to have in mind. What we are doing to our minds, to our brains, where we are thinking a lot about the future. Next, please. Okay. And there's these two colors. The orange is for the bad things, and the Blue things are the good things, and is and on orange, the activation leading to dendritic loss and decreased volume of the brain, and the blue one is activation leading to dendritic growth and increased volume. That cause the chronic and acute stress. And well, we have to work more on mindfulness users because we have more activation than acute and chronic stress people. Uh, and more brain atrophy who has continuous or chronic stress. Next.
1 second here. Oh, there it is.
Okay. Um, I like this slide because we can see the level of impact depends of the what are we doing on our lives. If we just have the self isolation, the effects of COVID, but we're going to have anxiety, depression, sleep disturbances, lack of exercise, and the measures we have to work on is telemedicine, regular phone contact, virtual exercise, lessons, classes, and if we have COVID-19 in patients with mild or moderate, we have to be self-isolated, hospitalization if clinically indicated. And well, we need to monitor fatigue, anxiety, depression, uh, promote chest physiotherapy, which is one of the things that we have to keep in mind. And work together with the neuropsychiatric working on delirium and psychosis protocols.
Mm-hmm.
And well, if we have patients with severe COVID, well, they need hospitalization with monitoring for assisted breathing. And well, the rest of the things we have to work at the hospital. Okay, next, please. Okay, this is the hit and run theory that we have before COVID about uh, where does Parkinson disease come. And we all thinking and asking what will happen after COVID-19. Is there a post-encephalitic Parkinsonism? We don't know. But we have a clinical manifestation that we have to look at, and they are hyposmia and hypogeusia. Um, the next, please. And well, I uh, um, sometimes we talk about pandemic just for infections, but 2 years ago, Bastian Blum and Ray Dorsey published this paper about talking the real pandemia that we have, and it's Parkinson. It's the first neurodegenerative reason of it's Alzheimer, but the expectation or the projected numbers of individuals with Parkinson disease and the future may be increased and maybe will be the first in the first place instead Alzheimer. I'm talking about the neurodegenerative disease.
Okay.
Next. And well, in conclusion, PD patients have more risk to develop COVID-19? Probably not. Which is the clinical manifestation of the PD patients? Motor and no motor, And we feel that it may be transitory. We will be better if we don't stress too much.
Mhm.
And which is a clinical manifestation of of the patient. It's like tutti frutti language. Sorry,
It's okay.
associated to COVID-19. That's the reason is because I have given this talk a lot of times, and every time I make this slide is another information, the new information, the latest information.
Sure.
And the clinical manifestations where we see hyperkinesia, tremors, myoclonus, and Parkinson's at this time is very rare. We have these two cases that I commented: the Spanish patient and the man who come from Israel. And the clinical manifestation and outcome of COVID-19 in PD patient probably is similar to the rest of the patient. And the outcomes depends on the fragility of the patient. In fact, there is the need of more studies, maybe outcomes from the people who began this year having COVID and the patient of Parkinson disease, how is going on with this hard days or these difficult days. The next, please. This is the latest slide, and this is the team of my neurology service at the university hospital.
I've been there.
This is yes, you were with us, and this is 1 month before pandemia, and the next picture we have is how we work together now by the virtual mode. And this is my Twitter
Right.
if you want to follow me. And this is my mail if you want to write something. Um, uh, I this is these
Well,
are
thank you. Yeah, actually, I follow you on Twitter and, well, everywhere, but you post a lot of really great stuff on Twitter. So, folks, if you're on Twitter, and I don't use it very much, I only follow a few people. I rarely post, but Dr. Ingrid definitely has some great stuff on Twitter she puts up and shares. Um, this has been great. I learned a lot. A lot of things to consider in this whole thing. In fact, I'm going to stop sharing for just a minute. That was the last slide, right? Yeah, okay.
Thank you, and I apologize my English because I in Spanish I talk very fast and I try to make the same in English. Sorry.
Oh, no, don't worry. I mean, I am very, very sorry to everybody for the technical issues on my end. I just didn't expect to have these issues today because I've never had them before. So, but anyways, I really appreciate you joining us. Thank you. Are there any questions? Anybody have questions for Dr. Ingrid? If you do.
I do.
Yep.
Okay, I'm going to make it in Spanish because I don't know the translation of one word.
Sure.
Okay. ¿Qué es mioclonis?
Mioclonías.
¿Pero qué significa?
Son sacudidas. Shakes,
okay.
like shakes.
Shakes.
Myoclonies is like shakes.
Okay.
Myoclonies, mioclonías en español.
Thank you.
Okay.
But I think that the best information that we have now is the way that we deal with the problem.
Okay.
And it's something that we can work not without medication, without therapy. It's mindfulness, exercise, and that's the one of the things that we must work on.
You know, it seems like we already have depression and anxiety on the list, which is they usually, everything is generally speaking, but usually rank fairly high as a non-motor symptom for people with Parkinson's, but also for people in general right now, I think, with the lack of a normalcy. Nothing is completely back to normal like it was, like we were a year ago. So we're still dealing with this. I know we still have people here, and we're able to go out and do things here. It's not so bad. You wear a mask and follow the rules. Yet there are still occasions where, because of the state laws here in New York State particularly, where you cannot go into a building if they've had a COVID case. You're not able to go in for 28 days because they're all quarantining. So if you're going to visit with somebody, unless you're an essential worker, you need to do it through a window and sit outside or stand outside. And I go to 2 different senior living facilities where around the perimeter of the building are chairs. And I see people sitting in chairs visiting with people through a window. And I suppose that's better than not seeing people, but that's just not normal. And the depression and the lack of activity and all the things that you shared in this is all the more reason for finding a way to. Russ is going to go over exercise snacking with us in a little while, and like his ideas for just doing little things that are part of your daily chores, let's say, daily activities, but make them into an exercise is like brilliant, I think. And this way, it offers the opportunity to do something in the way of exercise, cognitive thinking or training, multitask training. And also, we have a piece on mindfulness this time around because it's so important to be in the now, probably more than ever, just emotional health, mental health, physical health. They're all tied together.
Yeah, but well, we need to be more brave to keep going.
Yeah, I agree too. I think I agree.
Life goes on. It's like the younger people that has they said the flow. Let it flow.
Yeah, it's true.
What can we do against this?
Yeah.
Get it flow.
Yeah. Good point. And any other questions before we move on?
Yes, I had a question.
Yes, Daniel.
For me, I run the Rock Steady boxing program, and so, I've seen a lot of my fighters just being really uneasy and, like we talked about, scared really, or just stressed about it. In your slide, you're talking about it doesn't attack people with Parkinson's as with someone without Parkinson's. What would be a good way of speaking to that, to my fighters, to maybe calm their nerves a little bit with regards to the coronavirus?
Yes.
¿Necesitas apoyo, doctora?
Pero es
una pregunta de apoyo.
Ajá.
Estaba comentando aquí que en tus diapositivas comentabas que las personas tenían un poquito de estrés, tenían una situación con esto del COVID, entonces que él manejaba, entendí que gym boxing.
Sí.
Entonces, ¿cómo podríamos manejar con ellos? ¿Cómo podríamos hablarles a ellos para calmar esa situación con las personas que tenemos Parkinson?
Okay. No. Entendí. Sí. Well, I think the first thing is that maybe stress comes from that some non-motor and motor symptoms are getting worse, and we are thinking the worst of us. No, it will be worse, and we're focusing on the future. But the first thing I must have in mind is that it depends of the dopamine, the cognitive cognitive flexibility that I talk about. And if I stress, I reduce the dopa levels, and it will be like another and another and another. Entonces, work with the stress means that don't think a lot about your stressing. Second, their caregivers and the family, the friends are the very important in this part, because we are now in our houses with the most important things that we have. And it's not our cars and our money and it's our family, our friends, and maybe talk with friends, not toxic friends, because toxic friends are very bad. Um, just talk with something that make you smile. And remember, Dr. Estrada told you, flow, let it flow. Don't stress, don't think too much. Okay. Other things I saw. If you like dogs, you can have dog, and dog is like a dog therapy. You can make a lot of things to forget, but don't focus. If it's like the said that depression is like a black dog, and if you let the black dog, symbolically talking, uh, abrazar,
Embrace.
embraced.
A hug, embrace.
Yes, you're lost. So every time you feel stress, keep trying on what is happening around you in this moment. Mindfulness, work on mindfulness. Okay. But I think everybody is on this. Sometimes we desperate because I want to go to the stores and I want to live like I used to live. I want to make a lot of things, but not all is bad. I have to focus on the good. Maybe if you write in a list, what do you like in this day, in this morning? Maybe I love the my breakfast, and or I love the sun, or I love the sky, something like this. Maybe you are beginning to work on this.
Correct.
So actually, so that sounds kind of like I've been kind of doing that myself, just based on some research. I finally got into a little bit of living in the now, or being mindful, let's say, to some degree, and being thankful for my health is very good. I'm very lucky. I've had issues; they're gone. I'm healthy. But the sky, my two dogs. It's interesting. It makes a difference too, because I'm used to being out traveling and going to Monterey a lot and seeing my friends in different places around the country and around the world. I miss the people a lot. Fortunately, we have technology. We have Zoom, but and there, I'm kind of interrupting. I'm sorry, but I've this approach has been really good for the people who I work with as well. Exactly what Dr. Ingrid just said. But everyone's different too. Everyone responds differently to those kind of things, and I think it's hard to hit everyone with something that works as far as speaking to them about. Maybe the majority will respond to something like what Dr. Ingrid expressed, and some may not. It's definitely a challenge, and I can. By the way, Daniel was a guest on my podcast recently, about maybe a month ago or so. He has 3 Rocksteady boxing facilities in Northern California. He's doing really great work. The interview is one of my favorites. So I'll share that in the follow-up email so you all have it. It's in the playlist near the top of the list of interviews. But how are you people doing overall, Daniel?
They're doing well, and I like the mindfulness. If the news is really heavy about the virus, I always do a get to know you question in every class. And some days I just say, hey, I just want one thing you're thankful for.
Wow, great.
And that helps because you got 20 fighters. And after you hear 20 people giving one thing they're thankful for, the whole room just lightens up and we feel better. So I definitely do that. One of the tools I've learned in life is if you're having a bad day, it's what are 5 things you're thankful for? And it's just basics. It's going back to basics, and it changes the way neurologically you think, and it really just changes your mood. So I definitely I'm on board with that. one of my fighters actually has a dog for Parkinson's. It was a dog that they had to get trained up for 2 years, and now it helps him with getting up as well as depression and anxiety. So there is dogs out there for people with Parkinson's as well. I kind of wanted to speak to that.
Oh, that's good to know.
Yeah.
Thank you.
Yeah.
Excellent, excellent. Yes, Jill. Hi.
Hi, Carl.
Hi.
I am a rock steady boxing coach. And so I understand what Daniel's talking about with trying to get my fighters to come back in. I have a couple of fighters that are terrified of the COVID and won't even get out of their homes. So good question on that, Daniel. And as far as the dogs too, I got a dog in March, and I'm actually training her right now to be a therapy dog.
Nice.
For my and
The shelter dogs.
Huh?
The shelter dogs are very, very nice.
Yeah.
They find us.
Yes, they do. She actually found me, and she is actually working very well in the gym and brings a lot of smiles to my fighters because I'm actually training her in the gym.
Oh.
She's going training right now, so I'm doing training in the gym with her while they are fighting. And so they get a really big kick out of, I'll start doing something with her, and they all stop and turn around and look at her and they go, wow, she's really learning a lot. So it's really neat to see how the therapy dogs work. And, she's only a year old, so she still has a lot of puppy in her too. So it's been really neat to see how that works. So thank you for bringing that up, Daniel. I appreciate it.
That's nice. I love that, Jill. That's fantastic. Good work. I'd like to pick your brain more about that too this weekend. All right, gang. Well, what's that?
I'm learning a lot, so thank you. This is really cool.
Well, I thank you. Well, listen, Dr. Ingrid, thank you so much for everything you do. You do amazing work. You care about your people. Your patients love you. You probably know that, but I'm here to tell you I'm in communication. I text every single day, multiple times a day, with many, many people in Mexico, and especially Monterrey. They love you, and we love you, and thank you. Thank you for joining us. And you're welcome to stay if you want. If you can't, don't worry, but thank you.
Well, I want to share two things. Yesterday, I saw a patient with Parkinson. I make telemedicine. And at the end, we were saying goodbye, and the wife said, "Oh, wait," and then they turned the camera to the patient with the accordion playing, and he played me a serenade,
Oh.
and I was like, I didn't expect that.
That's
and so we have fun. That's life. We come to the life to be happy. And another patient of my age told me, "Oh, I can break dance like when I was young." And I said, "Either me, I can't." But he was trying to make with the rigidity, and so we began to laugh. So make it happy.
I love that.
Okay.
Great advice. Thank you very, very much. Thank you. Thank you.
Thank you.
Nice to meet you.
Touch with you soon. Thank you so much.
Bye.
Thank you, doctor.
All right.